Dave, we're at the top of the hour. You can begin when you're ready.
All righty, thank you, and hello everyone. My name is Dave Duff. I'm the head of marketing for Theranica USA, who is sponsoring tonight's webinar. And I'd like to thank all of you for jumping on this Zoom meeting and joining us for a conversation on the management of adolescents living with migraine. Theranica USA is the maker of Nerivio. So let me take care of the disclosures right up front, and then I'll introduce tonight's esteemed faculty. In terms of indication, Nerivio is indicated for the acute treatment of migraine with or without aura in patients 12 years of age or older. It is a prescription use, self-administered device for use in the home environment at the onset of migraine, headache, or aura. And in terms of important safety information, Nerivio should not be used by people with congestive heart failure, severe cardiac or cerebrovascular disease, or uncontrolled epilepsy. Nerivio should not be used by anyone with active implantable medical devices, such as a pacemaker or hearing aid implant, and it should only be applied on the upper arm over dry, healthy skin with normal physical sensation and without any metallic implants or in proximity to cancerous lesions. Nerivio has not been evaluated in pregnancy or those under the age of 12. For full use instructions and safety information, please see the Nerivio user manual, which is available at nerivio.com. Okay, with that said, let me go ahead and introduce our esteemed faculty. Dr. Andrew Hershey earned a Bachelor of Science degree with highest distinction and honors in biochemistry from the University of Iowa, followed by an MD PhD program at Washington University in St. Louis, Missouri. And after earning his MD and PhD, Dr. Hershey was a resident in pediatrics neurology and child neurology at St. Louis Children's Hospital and Barnes Jewish Hospital. Dr. Hershey joined the faculty at Cincinnati Children's Hospital and Medical Center at the University of Cincinnati College of Medicine, where he became the director of the Cincinnati Children's Headache Center and is the endowed chair and director of neurology and a professor of pediatrics and neurology at the University of Cincinnati College of Medicine. So Dr. Hershey's research interests currently include the improved diagnosis and treatment of childhood headache disorders, characterization of outcome responses, studies in new pharmacological and non-pharmacological treatment regimens, and the genomics of migraines. Through a wide variety of projects, he has been NIH funded since 2003, including a PI with Dr. Scott Powers, who is also on the faculty tonight. So welcome, Dr. Hershey, and let me introduce Dr. Powers very, very briefly. So Dr. Powers is a pediatric psychologist as well as a clinical child and adolescent psychologist and treats children with migraine and other types of headache. Dr. Powers is the scientific director of clinical research and trials for the Cincinnati Children's Research Foundation, the co-director of the Headache Center, and the director of the Center for Child Behavior and Nutrition Research and Training. Dr. Powers' research interests include clinical trials in the areas of migraine and headache, as well as child behavior and nutrition science. So welcome, Dr. Powers. Thank you both for being here. Next slide. Yes. So let's take a look at the objectives for tonight's discussion. We're going to talk about the unique opportunities when caring for adolescents with migraine. Then we'll review the most recent updates to the American Academy of Neurology and American Headache Society practice guidelines concerning the acute treatment of migraine in children and adolescents. And then we'll introduce the role of drug-free therapies for adolescents living with migraine. So, first question to get the conversation started, Dr. Hershey, can you talk about how you approach the first clinic visit with an adolescent patient and how might this interaction differ from the first visit with an adult patient?
Well, I think a lot of people that aren't used to taking care of kids and adolescents sort of direct a lot of their questions toward their parents. And they really have to first realize that the patient in front of you is the child and adolescent, and really engage them, but also stress with them the importance that they're the ones that can help them to make the decisions. I often tell them, I want you to make these choices. My goal is to educate you, not necessarily to treat you. Your parents have veto power, but you have the choice to make that decision. So starting with that approach that really focuses on the child and the adolescent and what fits their lifestyle, what fits their engagement as part of that process is very important. On the other hand, though, what makes it different than a lot of adult patients is you do have a whole family there. So oftentimes you've got, the child, their parents, one or both of which may also have migraine, and so sometimes it's the interaction of what goes on and to some extent, the biases the parents may bring with them or the unknowns the parents bring with them. So sometimes you're not just treating the adolescent child, but you're also treating the family and that understanding and education process so that you can move forward to setting the ultimate goals and guidelines. The other thing is we give goals for the child. The adolescents, as Scott can talk about, is a developmentally appropriate levels. Is that kids are very concrete. They're very setting goals, setting what gets you a grade A, what gets you accomplishment, what gets you achievement, and setting those up front with a child sets those levels of expectation. On the other hand, if you don't make those goals, you don't make those agreements, the kids will call you to task and they'll say, yeah, this didn't work. You got to fix it. And so it's, I think, very rewarding, but very challenging sort of thing to make sure you keep that in mind the whole time.
Well, thank you, Dr. Hershey. Yes, it sounds like a little bit different than would be your typical approach with an adult patient the first time. So thank you. So Dr. Powers, tell us a little bit about behavioral principles that adolescents can use to effectively manage their migraines.
Thanks, Dave. It's a really incredible privilege to take care of kids that have headache, because if you can help them change the course of this disease, you change their entire life. So when we think about the acute management of headache, a couple important topics are helping them understand and start to learn how to catch their pain as soon as it starts. This sounds simple, but if you think about being a teenager who might be busy in their life, have friends around, activities, you might ignore the pain when it first starts because it's not that bad and you've got other things distracting you. So we really work hard at helping young people start to appreciate what's your first symptom, what's your first feeling that you've had this disease, you know what your migraine is, you know when it starts. As soon as it starts, you have to let somebody know. And when you let somebody know, we can actually execute an acute treatment plan that involves behavioral principles like increased liquid intake and medication principles that Andrew will discuss later about medications that have been shown to be effective. But the behavioral part of acute treatment is starting to learn how to catch the pain early in every different facet of your life. And if you think about being a kid, you're good at distraction. If you're hanging out with your friends, if you're involved in a sports activity, if you're having fun, the migraine may not bother you as much when it first starts. So we really work with kids about catching that early and recognizing early and telling them their number one job is catch it early and tell somebody. And then they have to be part of a team. So they tell somebody. So if you're at school, it might be a hand wave to your teacher. So you can go to the office to get your medication or sports drink to get hydrated. At practice, it might be your coach. At home, obviously it's parents, but maybe it's with your friend's house. So you have to have an active plan, and we really work hard at that to make sure they feel empowered to have a moment to understand how to recognize their headache and deal with it and entrust adults around them. Very key to that. And then from the prevention side, there are several behavioral principles, including relaxation principles, that if you learn how to do those well, you can use those right when your headache starts, while you're waiting for the medication and the hydration to take effect, that can help you relax your nervous system. And relaxation and coping skills can be very effective for preventive treatment. So these are some of the things that are behavioral that we have kids learn, and they're very excited to learn them. And when they learn them and they start paying off, they get more confidence and more excited about their ability. So there's lots of things kids can learn, and it's very enriching to treat them.
I bet. No, that sounds really interesting because it's more than just the medication or the treatment, so to speak. You're teaching them life skills, it sounds like to me. So, and I think you had a slide. For some reason, it didn't come up for your answer there. But I'll move into the kind of the next question, and I think you were touching on it. Talking about interacting with adolescent patients. So, what aspects are really critical? When you're interacting with adolescent patients to develop trust, understanding, and really a collaborative approach to getting better.
Yeah, if we go to the next slide. If you're 14 and your headaches have started when you're 8 and you finally get to see Dr. Hershey and me when you're 14, because, you know, headaches are not often recognized and you deal with them. You finally come and see us, and we're starting to develop trust and understanding with you. You know, if you remember back when you were a teenager, if you were fortunate enough to be in a nice family and had loving parents that's tremendously supportive, had nice teachers, but at the end of the day, your friends were really central to your life. We did a study several years ago called the Friendship Study. It had also been done in young people that had cancer, arthritis, sickle cell disease. We went into schools and we just asked kids that had migraine in a classroom how they were doing with each other. They didn't even know who was the purpose of the study. And what they found was kids recognize who's not feeling well, be it cancer, arthritis, or headache. They go, yeah, you know, he's not well all the time. And they're very supportive. So helping kids really understand how to talk to their friends and deal with this with their friends to get support is a key component of, once they get confidence in their treatment plan, once they understand what they're doing, they can share it with their friends and their friends can support them. And generally speaking, that happens. Kids and adults are a little different. Study a long time ago by a colleague of mine, Hobie Davies, in a chronic pain population, asked kids, who are the people that didn't believe you had pain that was that bad? They were all adults. Parents, uncles, aunts, principals, teachers, because it's silent. You don't see it. You may think the kid's trying to get out of something when it's a real disease. So we have to help kids have confidence in their school note that says you can get water, you can go to the nurse's office or the office. We have to help them learn those skills and to develop confidence to use them. And when they do, they find it very fulfilling. And when they don't, Andrew and I say, give us a call. We'll talk to the teachers. It may be that they don't fully understand what you're dealing with, and it's our job to help them. So there's a lot of support there with adults. And the parents we see are always willing to learn, because that's why they see us. But giving skills to the entire family is important. And then, as Andrew said earlier, when you first meet an adolescent or a child in the office, look them eye to eye, sit in the chair, look at them directly, show that mutual respect, and listen. Listen very carefully to what they have to say about their experience and empathize with them, and also help them understand. Help them understand what that life experience is like with this disease, so they can say, oh, you got it. This is what I'm going through. Because as soon as you have that connection, you're going to have a great opportunity for any therapies you prescribe to be very effective, because kids are used to trying hard to do things that adults like for them to do. And if they find results, their adherence goes up because they find benefit from that. So it's such an opportunity and such a wonderful gift to work with kids and change the direction of their life. And if you can show some trust, some understanding, and make it a team effort, you'll get great benefits.
Well, that's great. Thank you, Dr. Powers, for explaining that. That sounds like a really holistic approach to really getting the adolescent on board with the entire treatment program. So thank you. So, well, let me turn to you, Dr. Hershey, and ask, so from your viewpoint, what are the key components of an effective acute treatment plan for adolescent patients?
Well, again, Scott and I are going to probably restate the same thing over and over again, which is getting the kids engaged. And there's been studies both in adults and kids that have asked the kids and the adults what they want. If we go to the next slide, it's pretty obvious. The first thing is they want the pain to go away and as quickly as possible. They don't want it to just get dulled. They just don't want it to, partway go away and they have to deal with it, but they want it gone. So we oftentimes start with saying, it may be a goal that's difficult initially to achieve, but our goal with you is to get work to the point that 10 times out of 10, your headache's gone within an hour. And then the second part of that is listed here is they're back to normal. Having the headache gone, but being asleep for 6 hours still means you've lost most of the school day. It still means you didn't go to basketball practice or soccer practice or choir or dance rehearsal or whatever you like to do, or even just hang out with friends. So you have to be back to normal. Also, kids' lives are very busy, as are adults. They spend half of their waking day or more in school. So you have to be flexible about how they can treat that. It also means that probably half the time or more, the headache's going to occur when they're at school. So across those multiple situations, and when they're not in school, they may be hanging out with friends, or they may be on the sports field, or in choir, or theater, or playing their video games. So whatever can fit well within their life. And if you give them something that's difficult for them to do, or that they don't want to do, or they're not engaged, or doesn't give them their control, or what's oftentimes phrased the locus of control, they're not going to do it, which can be similar to adults. They also don't want to, as Scott mentioned, their friends can tell them they're different because they have got a pain disorder. But for everyone, and since most of the audience hopefully has been through adolescence, during the midst of adolescence, it's a hard time and you don't want to stick out. So whatever you can do to sort of make that treatment controllable. If you have to get up and go to the nurse's office in the middle of a math test, it's going to stick out. You're the one then, ooh, what did you do? Or you got in trouble, all that sort of thing. And so kids don't want to be sticking out. They don't want their peers to see that. The other thing is, as Scott mentioned, you don't want people like teachers or parents or other adults to blow it off and say, oh, it's just a headache, don't worry, it'll go away. And so giving all that plan in place that gives the child, the adolescent, the control, so that when they feel the symptoms coming on, they can react in a confident, strong manner, knowing that they will be back to the normal day. One of the things we do mention, the daily life, one of the tools that we developed early on, the Midas does look at school, home, and social impairment. And a lot of adults will oftentimes think, well, kids are just trying to get out of school. And in fact, school is often the last thing that they give up. They start giving up social activities and home activities. So you also need to be able to think about how you can incorporate their acute treatments in all aspects of a child and adolescent's life so that they can comfortably control their headaches. And this isn't just acutely for their 10th grade years. Once they feel they've got that level of control, they may have headaches. I tell a lot of them, you may have headaches the next 30 or 40 years, but that doesn't mean you can't control them. So control is a key factor in being able to manage that.
Great. Well, thank you for giving us your viewpoint on that, Dr. Hershey. And so let's continue though, but kind of transition to practice guidelines. Can you kind of walk us through the latest AAN and AHS practice guidelines for the treatment of children and adolescents? Yeah, if we go to the next slide. So several different guidelines have been developed over the last few years. One includes trial guidelines. So Ishak Abafe and I led a group of 4 of us that actually came up with guidelines of how to do preventive trials in migraines in children and adolescents. This was followed more recently by both an acute guideline. This was co-developed by the American Academy of Neurology and the American Headache Society, and as well as a preventive guideline. And all of this put together, these guidelines purposes is to help us better do studies. That's why the IHS developed the preventative guidelines, but also to understand what the current state of the knowledge was as far as acute and preventive treatment. I would say probably one of the biggest things we found of all this is there's still lots of gaps to fill. There's still lots of holes. There's still lots of areas that we need a better understanding. Scott and I both, I think, firmly believe that we can understand better through kids and adolescents, that we can help teach adults how to manage things and not trickle down, which is oftentimes the case, because I think kids will give us a pure answer. On the other hand, it's oftentimes challenging to overcome things like placebo control. And that's because oftentimes when studies are done in kids, they've already been proven to work for adults. So there's a higher degree of expectation that they're going to work. And of course, everybody in the study thinks they're getting the active study. They never think they're getting the placebo when it's a placebo-controlled study. So as we sort of put those guidelines together, I'm not going to review them in detail, but hit some of the highlights. If you go to the next slide. So for the acute treatment guidelines, there were some key concepts that we wanted to really focus on. Similar to what I just talked about, what we want to express to a child or adolescent, the acute treatment guidelines align with that very nicely.
So you need to focus early. So catching it early is a key component. That does require the child to be engaged, the adolescent to be able to raise their hand and say, I need to start treating my headaches, or if there's a way they can do it without even bringing any attention to themselves, to also be able to treat it. Oftentimes the route of attack may be a guide, whether it's oral, nasal, injectable, or even devices that may help the child better treat their headaches in the setting that they're at. We did include a concept of lifestyle factors. Now, oftentimes in this, it gets to be a debatable area in terms of trigger factors. We don't tend to focus as much in the Cincinnati Children's Headache Center about avoidance of particular triggers, but rather the maintenance of healthy habits, recognizing things like skipping meals or not getting enough sleep or dehydration, so not getting enough to drink every day, are factors that can trigger or make you more prone to headaches. When it has been a look at adults, most adults that have identified trigger factors are actually wrong 60 to 70% of the time. And that's because of that idea of, I did this, I got a headache, that must be the cause. And then the next time it happens, they self-induce a headache. So we'd rather be proactive in saying, this is how you live a healthy life to avoid your headaches and avoid those triggering components, rather than restrict people. And then, like most all guidelines across the board, is to try to avoid the overuse of medication, as that's been clear evidence that that can contribute to the worsening attacks. We go to the next slide. So this is a table from the graph. It's small print. You can get in the paper and pull up the guidelines. But part of the focus in this, and I won't go through all the details, but you can see there's lots of holes in this table. So there's lots of areas yet to be filled. If we go with what we're telling the kids we want, which is your headache to be gone within an hour and you're back to normal, that's that very thin box toward the bottom. And there was only one medication that fell in there, and that was the zolmitriptan nasal spray. Even if we go out to 2 hours, we do get the reliance on the triptans and the NSAIDs. So rizatriptan, sumatriptan, different routes, as well as naproxen and ibuprofen. We do avoid aspirin in children and adolescents due to the fear of Reye syndrome, but as they get older, aspirin could potentially be placed in there. But I think the take-home message for the acute treatment is there's a lot of areas we need to work and focus on filling this to be able to provide the full armamentarium. Fortunately, there are new devices, there's new treatments, there's new compounds that are coming on board. So I think the future is very bright about the next time we do this guideline in 10 years, this table is going to be much fuller. If we go to the next slide, after the guidelines came out, we were asked to put together a sort of editorial about how to use these guidelines. And for the acute treatment, we wanted to provide the active participants, the people at home that are taking care of these kids, sort of first line, second line, third line agents to try and give them a little bit of a recipe book to do that. So based on the guidelines, this would say probably with the first line treatment for both children and adolescents is going to be starting with an NSAID. In this case, we recommended ibuprofen. One thing about pediatrics and adolescents is we do weight-based dosing. So in this case, it's a dose of 10 milligrams per kilogram of the ibuprofen. If that doesn't work, or you're getting effectiveness 7, 8 times out of 10, but there's 2 or 3 headaches out of 10 that is just not getting to that 1 hour headache freedom, the consideration of adding triptans or combination type medicines is the next line. If that doesn't work, the third treatment is, well, try another triptan. And that's because we realized early on with the triptans that if you didn't respond to the first one, oftentimes the second or third one may be responsive. One thing we didn't discuss as much here, but it's somewhat indicated in that middle second line, is the concept of multi-mechanism care, which is that you don't have to be focused or forced just to one treatment during a headache, but that in this case, NSAIDs and triptans actually can work in combination. So they work by multiple different mechanisms. So during a particular headache, although the studies look at a single focus, sometimes you can use multiple tools to beat the same thing. And so if they work by different mechanisms, you can actually get even higher efficacy as they may become synergistic and help each other out. If we move to the next slide, we'd be remiss if we just focused on acute medication. There's also prevention guidelines. The sort of spoiler alert here is there's even less armamentarium we have in this area. And it was mainly that there's a majority of studies failed to demonstrate superior over placebo. Scott and I actually were co-PIs with Chris Coffey on the largest pediatric and adolescent study in our CHAMP study, where we compared amitriptyline, dopamine, and placebo. And people often said, well, it failed because we failed to show a difference. I take it that we look at it that all three arms were very effective. If you took an adult study and had a 60 to 70% efficacy, you'd be thrilled about that. And why is that? That the placebo seems to be spy on kids. It gets back to that expectation. If you expect something's going to work, you can help enhance it. But you can also use that expectation clinically. And that's by engaging the adolescent, as we both said at the beginning. If the adolescent is engaged with you and making those choices, it's not just kids, but adults also. If they expect something to work for them because they chose it, and by choosing, they enhance that, you've improved it. And ultimately, isn't that what we want? Is that we want the people to get better. So that's part of that concern with the placebo effect. What we did recognize with the prevention guidelines is that lifestyle is a critical component to this, and that multidisciplinary, multi-combined action to discuss not just medicines, but how you actually can take control of your entire life to treat your disease. And migraine really is a disease, not an event. Comorbidities do have to be taken into account. Anxiety and depression are oftentimes co-associated in people with chronic and very frequent pain. And if you don't take care of the pain, the anxiety and depression can build. So taking care of the pain is important. And then the final thing we did recognize, it's a shared decision. It's not a doctor or a physician assistant or nurse practitioner telling the patient what they need to do, but it's actually asking the patient what they want done. We go to the next slide, then a similar table to before shows the prevention. And you can see here on this one, and again, these are clearly out in publication in both neurology and headache. You can see lots and lots of gaps. The bottom line in here is if you look at everything, the most effective treatment was really for chronic headaches in children and adolescents was the combination of amitriptyline and cognitive behavioral therapy. And that was really the only thing that really showed the highest level of confidence. Secondarily, topiramate and cinnarizine, which we don't have available in the United States, was sort of the second line. So it gives very few really indicators of what we can use for prevention. So we do have a lot to gain, a lot of knowledge left to fill in these gaps. Again, hopefully, as the years go by, we'll fill in more and more of these gaps, whether it's with new agents or realization of different methodology of studying older agents, many of the different designs that we've discussed in previous other talks.
Thank you, Dr. Hershey. And I just want to make mention real quick that we've got a couple questions that have come in on the chat box, really good questions. We're going to hold those till the end, but to the viewers that sent them in, hang on. We're going to get to those right at the end of the session here in the Q&A segment. So Dr. Hershey, back to the guidelines. Can you explain how you implement the guidelines and what the pitfalls are?
So if we go to the next slide. It's beginning to sound a little bit like a broken record, but I think that's important to really emphasize is that at all aspects, the first and foremost thing is not just to engage the child and adolescent, but really make them involved in the decision making. So for the acute treatment, I often ask them, I'll tell you what are options that you can do. What do you want to do? What works best for you? What would you like to try? Rather than me telling them. Our job as practitioners is to make sure that what we're offering is safe and effective, or as effective as we can make it. But we don't really know what their life is like. A flip side of being on televideo, telemedicine is you've got chances to see into families' homes, which can be very enlightening, and we can sort of see what they're having to deal with in terms of their life. And so asking them what works for you. And then after I'm done, when a psychologist like Scott comes in, oftentimes, say, Dr. Hershey said this to you. What can I do to make sure that works for you? Or well, how are we going to problem solve? How are we going to remove those barriers? You chose ibuprofen, but how are you going to do that when you're in second bell in school and you start to get a headache? And so they have to find that willingness, how it fits into their life and how you can do that. Additionally, in preventive therapies, it's similar. ask them, do you want to take a preventative therapy? I always give them the option, even if there are 20, 30 headache days per month, said it's always your choice. If you say no, you don't want to do it, that's fine. We can work with you. We can figure out other ways. Also say, our goal is to get you down to less than one headache a week. Once you get to that goal, and research that we've done has actually demonstrated that once you get to that goal, you can stop the medicine. You don't have to keep doing it. And so having a finite goal of when you can do it and not feel like this is going to be forever, which in a 16-year-old's life, 6 months is forever. Trying to say, you don't have to do it for 6 months. You just have to get to this point. And to get to that point, work hard, get yourself healthy, do those healthy habits. And then we can work with you, whether it's through cognitive behavioral therapy or behavioral interventions, or, we say, when we see you back in 6 to 8 weeks, and we try to see everyone back in 6 to 8 weeks, if things aren't working, let's try something else. And if we can't find something else, we have to get smarter. That's our job. I stole that from Scott's slides. That's one of Scott's slides. So, that's what drives us forward to do research, is to be able to answer those questions. And so we engage a lot of our patients in research, and they become participants so that they can help answer these questions. But we also tell them, it's your life. You need to find things to figure out with that. We'll give you the tools. And some kids that aren't necessarily getting better, we may have to re-engage some of our behavioral medicine colleagues even afterwards. And sometimes even at a 2nd, 3rd, 4th follow-up, they're not doing things. And I'll sit back and I'll say, whose headaches are they? Are they mine? No, they're yours. So who's got to make these decisions about what they want to do? And if we're telling you to do things you don't agree with, you don't like, tell us, ask us questions. Because the better you know what's going on, the better you're involved in those decisions, the better you'll do. And they may tell us, I really don't want to go to the nurse's office in the middle of math class, and I always get headaches in math class. I wish there was something I could just do at my desk. Or I really don't want to have 5 headaches a week, but I don't like the taste that the medicine gives me, or I don't like how it makes me feel tingly or sleepy. And so we have to work with them. So asking kids, having them fill in there is critically important.
Thank you, Dr. Hershey. That was very, very interesting. So let me ask you, while the guidelines are relatively recent, can you share any updates on approved treatments or published data since the guidelines?
So if we go to, the joys of doing this at home, you can hear my dogs.
Oh, yes. That's not complete without dog barking. That's okay. Yes, well, I was hoping my dogs didn't start barking, so I'm happy it's not mine.
So from the sort of treatment, there's a wealth of new medications that have been approved for adults, including the CGRP antibodies, the GPANs, the Dietins. None of those have reached the level of being approved for children and adolescents. They're being studied. Fortunately, though, some of the neuromodulation devices have been approved after safety testing in adolescents. So 2 of them that are available right now have been approved include the remote electrical neuromodulation, as well as the non-invasive vagus nerve stimulator. These provide non-pill form treatments that can possibly lead to help improving the child's locus of control, as we like to say. So can give them a different choice about how to manage their headaches.
Thank you, Dr. Hershey. So can you share the Nerivio clinical data that was published in Headache in last December?
Sure, go to the next slide. So this study started out, actually, take some historical precedents, as we started out in discussing of making it a blinded study, and actually the FDA thought that it was safe enough that we could make it an open label study. So it became an open label multi-center study. Like most studies, it was a 4-week baseline, so we can get sort of a true count of what their headaches are like. Then a 4-week treatment phase, and then 8-week follow-up, where kids could continue to use it freely. These were adolescents. So for those of you familiar with FDA regulations, 12 to 17-year-olds is adolescents, 5 to 11-year-olds are children, and then you get down to young children, infants, toddlers. They all had ICE3H3 episodic or chronic migraine. It's always a little soapbox of mine. All the headaches or the disease is migraine, the symptoms are headaches, and all headaches are episodic, whether they're 20 or 10 days per month. But I have to always say that every time I say that phrase. So they had to have at least 3 headaches per month. They were allowed to be on preventive treatment if stable. They had to have at least enough headaches that it was felt that during the treatment phase, they'd have an option to be able to treat one. And then we looked at the standard endpoints, which were primary headache relief, secondary headache relief, meaning was headache free, was it relieved, any associated symptoms, and then looked at 24 hours out. This compared, in addition to their ongoing treatments that they were oftentimes using at the phase. Next slide. So this just runs through the sort of the how the patient were developed. So the sample size we felt needed to be about 60 patients, needed 110 participants. This was started pre-COVID. In the midst of COVID, it was realized that it was very difficult to get patients engaged and enrolled, and there was a gap. The FDA also recognized that and said that there could be a study analysis to see if we could take care of the children then. If we look at that, then that was the enrollment phase. So 60 patients were enrolled. There were some that were excluded for not meeting the criteria, so 14 of those, and 1 was lost to follow-up. So that left 45 patients in the treatment phase, with 39 patients that ultimately treated a headache. There was an interim analysis, and this was when it was decided that that was enough at this point, that it could be proceeded, as well as an external DSMB that felt that the data that was accumulated was adequate to come to a conclusion about the safety, as well as making some efficacy decisions. And then the final 39 patients were the ones that participated in the statistical analysis to determine the response patterns and the pain relief at 2 hours. We go to the next slide. This slide then shows the open label effect. So as an adolescent study, we hit right the middle range. So of the 12 to 17-year-olds, most of them are 15. Unlike a lot of the adult studies where it's 80 to 90% female, it was actually a fairly good balance, 60% female, 40% male. They had their migraines or their headaches typically in the less than chronic area frequency, about 9 to 10 headaches per month. And some of those had all the features that qualified as a qualifying migraine. About a third of them had used triptans. A third also had migraine with aura. On the left panel then here, you see the results. For those that had pain relief, 71% achieved some improvement of their pain, and 35% the headache was resolved. So a third of the patients, the headache had gone away completely within that 2-hour window. If we look across multiple attacks, which is the second panel there, you can see these results were sustained over multiple attacks as the patients, the kids entered their open label phase. So the conclusions from that was that it was effective, it was safe, it was well tolerated. There was no serious adverse events, and none of the participants actually withdrew from the study because they were having adverse events. So being from that, it was felt that it could be approved by the US FDA. If we go to the next slide, the conclusions that came all of this was that the remote electrical device, the REN device, provides clinically meaningful relief of migraine in adolescents, that you could have pain relief within 2 hours, and a significant number had pain freedom. It's tolerated and safe, and may be more safe than pharmacological treatments, as well as more effective. I say may because this is comparing to their ongoing treatment, and obviously they enrolled in a study because they may not have been as happy with their active devices. So there's some selection bias there. But the favorable safety profile, the clinical benefits that we're seeing really did indicate that it added a new tool to our armamentarium to be able to help treat kids and adolescents.
Thank you, Dr. Hershey. So as you mentioned, so this was an open label trial. How did these results compare to the sham controlled trial in adults that was also published in Headache a couple of years ago? Yeah,
so if you go to the next slide. So I'm not going to go into this detail, but if you look at it, it looks very similar, with the exception that it was a sham control. So there's 7 sites across the US and Israel. The adolescent study was also across multiple sites. The inclusion criteria was mainly restricted for 18 and up. Mean age is 44 for active, 42, a lot older than the 15-year-olds that we were taking care of. But the pain relief was the primary outcome, as well as brain freedom, and something that was looked at here as most bothersome symptom, which we struggle to really quantify well in kids. If you go to the next slide, actually took the top two studies and put them right next to each other. So you've already seen the panel on the right. So this is the single attack panel I just showed you that showed pain relief was 71% in the adolescents, and pain freedom was 35%. If you look at the left panel, you can see, and I guess the light teal color, the pain relief for adults was 66%, pretty close to 71% for kids. So really no difference. And then if you look at pain freedom, it was 37 versus the 35 for kids. Again, you see the placebo in here, but I think one of the important take homes here is that the comparison of these two really shows the efficacy was the same for the adolescents, even though it was an open label study, as it was in the adult blinded sham controlled study, which I think can give you strong confidence that the way that it's working, the efficacy of it's working, is the same, even though there wasn't a placebo arm in the study. If we look at the next slide, it does show the side effects in the adults. As I noted in kids, there really weren't very many side effects at all noted. Maybe a little bit of tingling in their arm, but nothing required treatment intervention. Similarly, in adults, there were very few significant side effects. A lot of them were the local site components, including the sensation of warmness.
Well, thank you, Dr. Hershey. It's reassuring to see that the results in both efficacy and safety were similar and consistent across the two studies. So the next question's for both of you, but we'll start with you, Dr. Hershey. Can you talk about the mechanism of action of Nerivio a little bit?
Sure. So I'm going to try to talk about through the sort of the neurosciences, and I think Scott will talk to you about how do you translate that to a teenager. Right. So if we talk about this, what is conditioned pain modulation? Well, it's not TENS. It's not the component when somebody has an injury in their leg and you can put a TENS unit on and you block that pain by blocking the signal from actually being given to the brain. But it's a different process, and that is that if you can stimulate something just below the pain threshold, you can actually focus on central pain processes, and that's called remote electrical neuromodulation. So it uses the endogenous analgesic mechanism based on the 1970s observation of diffuse noxious stimuli, or if you stub your toe, if you squeeze your other toe, it doesn't hurt quite as bad, sort of concept is what this remote electrical stimulation is. If we go to the next slide, it shows a cartoon that sort of separates these two concepts out. So the TENS unit really relies on the gate control theory, which is if you overwhelm the gates, the pain transmission can't get sent upward. Whereas if you look at the conditioned pain modulation, it's more of a subthreshold signal, gets all the way to the brain, and then disrupts the pain processing in a descending mechanism. So this shows a little bit of a cartoon mode. If you go to the next slide, it sort of looks at all the different parts of the brain that may be involved with this component in terms of the flow of the brain. Some of this is theoretical, some of this is shown, but I think the important modulation is usually the pain comes up to the head, but if you can modulate it through modulating things like the periaqueductal gray or the subarticular dorsal nucleus or the local nucleus, basically the brainstem is you're affecting it. And many of the theories that come out of several labs, including the largest work that Rami Bernstein's done, has shown that there seems to be some generators in the periaqueductal gray and thalamic area for migraine. So the concept of the conditioned pain modulation is you're disrupting these signals through the concept of both the noradrenergic as well as serotonergic pathways, the control inhibitory and control pathways. So you're basically disrupting the brain processing and being able to do that. If we go to the next slide, this is sort of the summary of the difference between Ren and the gate theory, but it is distinct component. It really uses the brainstem mediated inhibition process. So we're really trying to get to functioning the brain component. You can do this by stimulating at a sort of a sub-threshold, enough that the patient feels it, but that it isn't painful in and of itself. And it can last for quite a while. Now, how do you translate that to kids?
Yes, that is the next question. So Dr. Powers, over to you. That's the second part of the question. How do you translate that complex information to an adolescent? Whoops, you're on mute, Dr. Powers. There we go.
I think it's the next slide too.
If you can show the next slide. You know, kids love to learn. So if you sit down and talk to them about their migraines and their brain and how their body's working, you really have an opportunity to explain to them something as complex as what Andrew just went through to help them appreciate that. In fact, we're doing some functional MRI studies now, and one of the things that the kids can earn as part of their participation is a 3D printout of their own brain, which is pretty cool to put on your desk.
Mm-hmm.
But it's also something to be curious about, because your brain and your migraine is what you're working on if you have this disease. So it really is helping them appreciate what Andrew just said, that your brain takes in lots of information. And if you stimulate one part of your body that sends information to your brain may be able to push information back down to your body, which is sort of described in this slide with this young lady with the Nervio device on her arm. It's really kind of cool to think about. You can control your pain by something that you can activate, that you can be in charge of, almost like biofeedback and relaxation. Devices have a similar quality to, like, hey, I can do this. And it's safe, and it's something I can be in charge of. And it's discreet, as Andrew said, but partially helping them appreciate how complex the pain processing is in their brain, and that their brain can actually push against pain. So that this device sends a signal and your brain goes, well, got a lot of stuff going on right now. I'm gonna push down the pain signal for my headache starting because I'm busy with other things. And kids are pretty amazing when you talk to them about being distracted. If you've ever been out walking around hiking or whatever, and you come back and you're like, hey, I got a scratch on my arm. You didn't notice it when you're out distracted, enjoying the environment. Kids are very able to appreciate the difference between, oh, yeah, if you said you were gonna like scratch my arm, I wouldn't want you to, but I don't know, I've been injured on a field and it didn't affect me till later. So this concept of how your brain can control pain is very commonplace for kids if you help them appreciate it in their own lives. And as soon as they get the concept, it's like, hey, makes sense to me, let's give it a shot, just like Andrew said. If you can engage them in something that works for them in their environment, and it has good scientific basis, they can be incredibly effective with it.
Thank you for explaining that, Dr. Powers. And one of the important attributes that was mentioned earlier in the discussion was the need among adolescents to have confidence and a locus of control when treating with an acute therapy. And you've mentioned it a couple times, Dr. Powers, about the fact that they turn around with their cell phone and because there's an app that they download. So can you spend a minute talking about the digital aspect of Nervio and how that may actually help uptake and adherence?
Sure, we all love our phones, right?
Right.
Most people have
Can't
their
live without them
phones all the time. And most of the time, if you have a phone that's got a problem, you ask someone who's 14 to fix it for you. So the fact that there's connectivity between reporting on my headaches, understanding what's happening in my life, the fact that it can be sent to my treatment team, and also sort of a reporting, sort of a scorecard. If you're a young person, you're used to going to class, having grades, working with people. So if Andrew and I are working with an adolescent, it's like, okay, let's get you down to one headache a week or less. No headache lasting more than an hour. No getting in the way of your life. They go, okay, I got my goals. Check, check, check. Something like this gives them a chance to measure that and give them a sense of control. Like, hey, I'm making progress. And that progress also works against any feelings of fear or worry about future headaches. And that's pretty powerful if you're 14 and you're worried about the weekend and you want to go see your friends. You're like, oh, I'm worried I'm going to get a headache. I said, well, look at your headache diary. How you doing? Well, I haven't had a headache on Saturday for 3 weeks. I go, okay. That's that cognitive part of this. Like, well, I guess I can probably start to predict I'm going to be fine. So the fact that there's a digital health component to this device and the fact that kids can interact with it makes them even more highly engaged in their treatment. Not forever. Kids aren't going to fill out a diary for 10 years. But if they start to get better, it starts to reinforce that behavior. It works for them. Think about your own life. If something works for you, no one needs to remind you. You just take care of it. And kids are the same way. So this is a nice way to bridge that effectiveness for them and give them real feedback on how they're doing. And plus it fits right into their lives of the devices they use every day. They're on their phone. They want visual feedback. They want information. They're very willing to accept that. And this is a nice component of the intervention.
No, that makes a lot of sense. And the way you explained it's really, really enlightening. Thank you, Dr. Powers.
And on
So
top of that, it involves some relaxation treatment that helps them prevent their headaches. So it's a win-win.
Right. Yeah. No, that's a good point. Very good point. So, Dr. Hershey, I was going to turn to you and ask. So now, when you're treating a patient with Nerivio, how do you, explain to the adolescent how to incorporate this therapy into their daily activities, and what migraine treatment practices are you sure to discuss with the patients?
So it gets back to some of our guidelines as part of it. Part of it's just as Scott was talking about, helping the child understand how to do it. So it's nice to have videos, it's nice to have pictures. Those are widely available for being able to how to do it. But like oral acute treatments, we talk about try to treat as early as possible. So catch it as quickly as you can. Having a device you can just put on your arm, pull out of your backpack, control with your phone, and we usually provide a school letter that says, they're allowed to do this so that they can pull their phone out in the middle of class to be able to control it. And they don't have to leave class because it's not taking a pill. It doesn't have to have a nurse administer it. In fact, the nurse would probably have no idea what to do about it. So the kid would have to teach the nurse, if anything. We try to help them a little bit by positioning and showing an example, and oftentimes use the example. You've seen those joggers that wear their smartphone stuck to their arm, and sort of doing the same thing, or sort of putting it, although the device is also contained. One of the things I think is really important, kids had a lot of, shouldn't say fun, but a lot of feeling they can control it, is a dial on there, so they can dial it up. Oftentimes we will hear from one of the families that they'll try to dial it up all the way just to see how bad it feels. And so, not that that's encouraged, but kids are going to experiment. And so they know it's not going to hurt that bad. So I can control it and be able to guide it to my point. And then they also know then for future headaches, that's where their point is. So they can get to that point quickly, and then they can know that it automatically shut off by itself. So they can go back to class and feel this slight warm tingling in their arm as their headache sort of dissolves away. There are, as I said, plenty of the apps available. There's plenty of instruction videos, examples. It's of course very electronic and web friendly, so they're oftentimes on it. In fact, I've been with teleconferencing or telemedicine. I've been talking to them about it and realized they're already on the web page looking at it while I'm talking to them. So they sometimes jump ahead, and I think that helps reassure them when they see something in print. And to them, in print means somebody else has talked about it, and it's on there. And one of the things we did mention in our guidelines, the component or the thought of multi-mechanism treatment, where you can combine an NSAID with a triptan. The one thing about the Nerivio device, you can also combine it with air. We don't know how it works in terms of is it synergistic, but because it does work by a different mechanism that's not chemically but actually electrically induced, the speculation would be that it would only further enhance the possibility of the NSAID or the triptan they may already be taking. And given the very low side effect profile of the Nerivio device, then it should be expected to work well.
Well, thank you for sharing those best practices, Dr. Hershey. And well, the next question is one I'll take real quick. The question is, how's Nerivio prescribed? So let me spend a minute focusing on that, and then we'll get to the Q&A. So on the right side of the screen is the prescription information and enrollment form into the Nerivio Express program for the viewers out there. So patient information, then HCP information, and then the insurance information at the bottom. Simple one-page form. Tried to make it as simple as possible. And then on the left side, you can see you could submit via fax, email, or EMR. So all the numbers are on there, and this information is on the website as well if you want to refer to it at nerivio.com.